Thanks, Dr. Tom Lendvay, for talking today about CSATs. What is CSATs? Actually, first of all, what does it stand for, and then what is it?
Yeah, CSATs stands for Crowdsourced Assessment of Technical Skills, and it is a method to objectively and accurately appraise healthcare providers' performance in their line of work. We focus on surgical skills currently, but it can be applied to many different areas within the healthcare system.
Okay. So who uses this service?
So CSATs is typically used currently by credentialing bodies in hospitals who are trying to ensure the quality of their providers. So surgeons who are using different technologies in the operating room, making sure that they are fit, properly trained, proficient in their technique, as well as in training institutions. So centers of learning where there are surgeons in training who are advancing through the tiers of residency programs, and we need some way of objectively tracking them along their pathway.
Okay. So give me for instance and how it gets, how the crowd gets used to assess.
Yeah, so the crowd initially started off as people that were recruited through crowdsourcing platforms. In particular, some of our early validation studies in this method were using Amazon.com's Mechanical Turk crowdsourcing platform. And over the years, what we have done is we have honed the crowd. We've identified and pre-qualified the reviewers. So now our system is a composite of reviewers from mainstream crowdsourcing platforms as well as experts in that particular field of whatever performance is being appraised. So if you are a general surgeon doing intestinal surgery, there are experts who are experts in that field of intestinal surgery that are also reviewing these performances and providing feedback. So the feedback is both qualitative. How does the provider do relative to their peers using these objective assessment tools? And then also qualitative. How can this provider improve their performance going forward?
Okay. So what does the data tell us about the correlation between a performance assessed this way and outcomes?
Yeah, so in 2013, John Berkmeyer at the University of Michigan and his group in the Michigan Bariatric Surgery Improvement Collaborative, they saw that there was a direct correlation to the technique of surgeons doing bariatric surgery. These are laparoscopic or keyhole incision surgeries for patients who have obesity and are getting procedures to help reduce weight. And it turned out that if they had peers in their community, so surgeons who are good at these procedures, reviewing videos of other peers in the community doing the surgeries, that the scores provided by those blinded peers, so people, they don't know the identity of the surgeons they're reviewing, those scores correlated directly with the patient outcomes of those surgeons who were performing in those videos, not just in the one video that was assessed per surgeon, but in the entire practice of that surgeon over the course of the year. So if you were in the bottom quartile of performance compared to the top quartile of performance, you had a 5-fold death rate,
wow,
3-fold complication rate, and 40% longer operative times in your entire practice, just based on the technique observed within the video.
Wow.
So we know that technique directly impacts patient outcomes, and so we fast forward to a system where we can readily appraise surgeons, where we have this opportunity to do it rapidly, so that if there are surgeons who have any weaknesses, they can get feedback right away about how to improve before their next case.
Mm-hmm. And are they using this technique in training programs?
Yes. So in training programs, it's used along those lines, providing feedback to the trainees, as well as being able to longitudinally track the performers. So there are increasing demands from the oversight committees of residency programs that residencies are now objectively appraising their trainees. Right now, the system is fairly subjective. Trainees have their mentors and faculty intermittently give them ratings on interpersonal communication skills or their patient care abilities. And it really comes down to somewhat of a popularity contest. If the resident is very pleasant, well-liked, chances are the faculty are going to rate them very well. And the opposite is true. If a resident just has a whole bunch of hiccups in their program, they may be downgraded. And it's really unclear how objective this system is, and yet it's really the only system we have. So CSATS provides programs with very hard objective data about the technical performance of the residents as they're going through their practice.
All right. And is it limited right now to laparoscopic and robotic surgery, or are you also capturing open cases?
Yeah, so it is valid in open surgery as well, and that's important because still the majority of surgeries in the United States are being performed in an open fashion. There are 51 million surgeries performed annually in the United States. About 8 to 10 are performed laparoscopically or robotically, and the rest are done in an open fashion.
Mm-hmm. But is CSATS capturing that, or how do you?
Yeah, so if there is, it all comes down to the opportunity and the ability to capture good quality video of the performances. In a laparoscopic or robotic fashion, it's very easy because everything the surgeon sees is what the reviewers would see because it's coming from the camera's eye. In open surgery, there's more reliance on the systems in the operating room, such as cameras in the overhead lights, or literally a camera set up on a tripod or head-mounted cameras on the surgeons to obtain the video. And there's high variability in the quality of those videos. And thus, it's important that we make sure that the quality is there before we can proceed.
Right. What else? What else do people need to know about CSATS?
Well, we have started and really established value in the realms of surgery, surgical technique. This process, this methodology, is actually valid also in communication skills. And that opens up a huge area within the healthcare industry because providers right now are in part reimbursed on how patients perceive their interactions with their providers. And that's only going to become more prevalent. There's Press-Ganey assessments of physicians and hospitals. Even nursing staff get evaluated by patients. How providers interact with their ancillary staff, doctor to nurse interactions, administration to nurse interactions. All those interprofessional or interpersonal communication skills are going to be assessed to some degree, and we need an objective system for that. And this is really a rapid way to accurately appraise communication skills. We have just completed a study with the Seattle Children's Hospital and the University of Washington, their autism group, where our system was able to be used to actually identify different degrees of abnormal behavior among children going through different types of little tests to see if they have autism spectra. That's not a technical skill. That's a behavior skill. And of course, we would believe that large groups of people are very good at identifying whether communication is good or bad, or whether the interactions are positive or negative. We've evolved over millions of years to be able to read people. Mm-hmm. And so we believe this system is perfectly suited to solve that problem.
Interesting. Okay, very good. Well, thanks for taking the time to talk to OnSurge today, Dr. Lendvay.
You're welcome.
Thanks for checking out the Op Report. Help us keep conversations alive on topics in general surgery. Check out more episodes of the Op Report and other OnSurge content here at YouTube. Find us at Facebook, follow us on Twitter, and find our homepage at onsurge.com. Join the conversation and tell us what topics you'd like to hear about and what people you'd like to hear from.